Hi, I'm Kirsten Tillisch, and today I'm going to talk about centrally mediated abdominal pain with comorbidities. So I'm going to start today with a case. This is a 32-year-old white male who presents with severe abdominal pain for 7 years. As a teenager, he had a history of attention deficit disorder. He had depression, which was initially treated with an antidepressant, which he didn't tolerate at all, made him feel out of control, and he refused to ever take again. But then with behavioral therapy, and he did okay. Generally, though, he had low self-esteem, he was underweight, he had a poor body image, and really struggled through high school. When he entered college, however, he did much better. He felt healthy. He started to study nutrition. He became a bodybuilder and really interested in fitness. He became, in his words, a health nut and maybe even a little bit obsessive about health and diet. Then, as he graduated, he and a friend started a fitness business. He was very excited about it, but then he said his friend cheated him, ruined the business, and his life kind of fell apart really early on. He started to have more severe anxiety. He was not sleeping very well at all. And though he hadn't been someone who drank alcohol much in the past, over the course of a few months, he started binge drinking. And one of these binges, he got very ill. He had repeated emesis. And while he was vomiting, he felt a tearing sensation in his right side. And that tearing sensation and that pain lasted for weeks and then really never completely went away. And he felt like somehow he damaged his body. That pain's been there ever since. He describes it as being 24/7 present. It's a burning sensation and then intermittently has stabbing. It's usually just superior to the umbilicus and to the right, though it can go all the way from the ribs down to the pelvis, and sometimes will even cross the midline. It's usually around a 5 out of 10, but it could be as low as a 3 out of 10. And at its worst, when he's bending, twisting, or lying down flat, particularly at bedtime, it can be up to a 10 out of 10. And so the fact that when he lays down to go to sleep, this pain becomes so unbearable, it makes his insomnia much worse. And he's really struggled with that. The pain doesn't seem to change whether he eats regularly or not. It doesn't matter what food. It doesn't matter if he has a bowel movement. It really is not triggered by GI function. In addition to his insomnia, he also has tension headaches frequently, at least a few times a week. He still has ongoing trouble with attention and sometimes feels brain fog. He has depression, which he currently feels is reasonably controlled without any treatment at all. And he has had multiple chemical sensitivities and intolerance to medication. Despite that intolerance, he does still take Adderall and temazepam he uses for sleep. In terms of his social history, his life has never gone back on track. He's currently living with his mother. He says he has no friends. He's too sick. No one wants to be around him. He's always in pain. He's had several jobs working for gyms as a fitness instructor, a trainer, but he's always had conflicts with other employees or supervisors and has not been able to maintain a job. He's currently on unemployment. He does not have any substance abuse history since those episodes of binge drinking that stopped when he developed his pain. He's seen many GI physicians. He's had a very extensive workup. His exam is not really that remarkable other than tenderness, even to light touch over the right abdomen, but also to deep palpation. He's had many lab tests, including porphyria workup. He's had cross-sectional imaging multiple times, always normal. His endoscopies, biopsies, normal. The only thing that was slightly abnormal was once on a HIDA scan, the ejection fraction was a little bit off. And unfortunately, based on that, a surgeon took out his gallbladder. They thought, well, maybe you have chronic cholecystitis. The surgery did not help. In fact, it made him a little bit worse. He's had other symptoms like palpitations, shortness of breath, back pain, neck pain. He's had imaging. He's had a pulmonary function test. He's had cardiac workup. Everything has been okay. He's also tried a lot of treatments. He was on proton pump inhibitors multiple times, didn't tolerate them. They didn't help. He tried NSAIDs for a long time, didn't really help. He did tolerate them. He ended up on opiates a few years back and was on chronic opiates daily for quite a while. He had some mild to moderate improvement of his pain with this, but he felt they made him kind of draggy and tired. His attention was even worse than usual. And with all the media around opiates, he started to really worry about being addicted to these dangerous drugs and decided to come off of them, which he did. So it's been 6 months. He was able to taper off the opiates. He has no interest in starting them again. They really didn't help enough. He's tried a bunch of different diets to see if that would help his pain. They make no difference whatsoever. He feels like his attention and his energy levels are best on a paleo diet, so that's what he is on right now. He's had trigger point injections without any benefit at all to the abdominal wall. He has been tried on a neuromodulator, but didn't tolerate it, stopped after just a few days because it made him so achy and he felt flu symptoms. He also was tried on pregabalin. It caused palpitations. After the first day, he wouldn't take it again. So he's really not had a good trial of any neuromodulator at all, and is really not very interested in doing so. He meets our criteria, the Rome criteria for centrally mediated abdominal pain syndrome, or CAPS. He has continuous pain. There is really no relationship of that pain with physiologic events. He has pain that limits his daily functioning. And this is an unusual criteria for a GI disorder, but with CAPS, it's usually associated with loss of function across multiple domains of life, whether it's interpersonal, work-related, family life, etc. And he has all of those. His pain's not feigned, and his pain's not explained by any other structural or functional GI disorder that we can identify or other medical condition. So he comes in distress. He says he needs help. What's wrong with me? We need to figure out why this happened and why it's still there. He worries that maybe he needs another surgery. Did the surgeon leave something inside the last time? He feels like he's not depressed. This isn't playing a role in his symptoms. If he could just get rid of the pain, his life would come back, he could get back on track, and things would be okay. Couldn't we just put him in the hospital? Couldn't we just do the tests in the hospital and figure out what's wrong? He feels like no one's taking him seriously, and he says, I know this isn't normal. I shouldn't be in pain all of the time. And these are associated behaviors that were described in the first paper when we put out the Rome criteria for CAPS. These aren't requirements for CAPS, but they're associated behaviors that are really common. So requesting multiple diagnostic studies and seeking out healthcare frequently, often multiple different providers. For example, this gentleman had not really stayed with any doctor for more than 6 months at a time and tended to go from doctor to doctor. There tends to be an urgent reporting of intense symptoms, despite the fact that the symptoms have been going on for many, many years in many cases. There's a minimization of psychosocial contributors, the feeling that those things are not affecting his pain or really the quality of life. It's the pain that is doing everything. And there's really a focus on complete relief of symptoms, not a stepwise movement towards feeling better. This fits right in with the pathophysiology that we understand about chronic pain generally, and CAPS in particular. CAPS is pretty uncommon, so we don't have any really good trials looking at the pathophysiology specifically. So we're really inferring from what we know about chronic pain that this is impaired central pain modulation. There's psychological pain amplification from hypervigilance, from catastrophizing and fear avoidance behaviors. And then along with it, some people may or may not have some associated allodynia, in his case of the abdominal wall. So what we tend to see is, starting here at the bottom, some sort of GI event. That painful event is filtered through the brain, so emotions and cognitions being layered on as we generate these conscious feelings of pain. And really what happens is that context of great distress and pain are put together in a memory. This encoded memory of pain then being replayed over and over anytime some external cue triggers that feeling. And so it really is a sort of a loop of pain that occurs. These patients often have comorbidities, whether they're headaches or back pain, fibromyalgia, other types of somatic pain, because those pain processes feed into this same sort of brain mechanism that occurs. It's very common for them to have depression. In CAPS, that's the most common mental health disorder, but anxiety and PTSD are common as well. How much workup do we really need? You know, probably minimal. Each person's going to be different because there are variable presentations, but we want to, of course, evaluate for structural disease and address any alarm symptoms. Beyond that, we really want to avoid surgical intervention if we can. It turns out that in people with chronic, ongoing, unexplained abdominal pain, surgery increases symptoms in about a third of them. And in this small study of 44 individuals, it didn't help anyone. In fact, a lot of people start their symptoms with a surgery that then is the trigger for their CAPS to occur. So what do we do now? Our goal is really to make a treatment plan for this person. And like any of our patients that we see, it really starts with our patient-physician relationship and trying to get some rapport and understanding of what our expectations are. And so I really want to ask, how can I be helpful to you? Now, in this patient, as I've sort of mentioned, the answer might be, I want you to figure out what is the origin of my pain and how can I get rid of it completely? And I've got to set the expectations appropriately that I'm probably not going to be able to do that. Certainly not going to be able to do it right now. And so I like to ask people to sort of set aside the origin theory. We might never know what's the cause of your pain. So let's set that aside for now, and let's just work on getting you feeling better in the moment. And what can we do for that? Can we do this in a stepwise way and in a holistic way? Now, when you have someone who has these comorbidities, it's very hard to get pain to improve when you can't sleep. It's very hard to get it to improve when you're depressed. We want to make an explicit connection between the comorbidities and the abdominal pain and emphasize those treatments that'll actually be holistically helpful. So for example, if I were to say to this gentleman who doesn't want to take medicines, well, mindfulness-based stress reduction is an evidence-based modality for chronic pain. It's been shown to decrease pain. Well, it turns out it also helps with depression and anxiety. So that might help some of those symptoms. And it probably helps with sleep as well. And it's a group intervention that is something that may help one of the other things that is going on with him, which is loneliness and feeling isolated. So making the argument for that intervention might be pretty easy for me. If I just said, if you don't want to take medicines, I'm going to have you meditate, that's not going to fly, right? So we have to build our plan along with the patient with shared responsibility. Now, over time, I might be able to get him to be able to use a neuromodulator that may be helpful, but I'm probably in this situation going to need a team to work with me. And I'm very lucky at UCLA to have an integrative program where I have those colleagues in the same office that can do that. For other people, you may have vetted community providers that can help you. So what we're going to do now is we're going to talk to some of the providers that I work with who can help me improve the quality of life of this patient who has chronic abdominal pain.